if you were deployed as a surgeon, you are a leader. And you'll see that even if you're not in a leadership position. You'll have an FST commander and an admin, deputy commander. But when a patient comes in, nobody's looking at that MSc officer. They're looking at you and the other physicians. If you're deploying as a surgeon, you are a leader, whether you have a leadership role or not.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care.
All right, welcome to another edition of Frontline Surgery, Mastering Military Trauma Care. I'm Jeff Conner, a current Army trauma surgeon, joined with my co-moderator, Dr. Yelon. Will you introduce yourself for us?
Hey, my name's Jay Yelon. I am a Navy trauma surgeon.
All right, in this series, we help prepare early career military surgeons for the realities of deployed trauma care, sharing key insights from those who've been there. Today's episode focuses on life and surgery at the Role 2 medical treatment facilities, specifically things you wish you would have known before deployment and what's different being at a Role 2 compared to civilian centers or even the Role 3 capabilities, and what you can expect from your team. We're honored to be joined by Colonel Retired Dr. Matt Martin. He is the Director of Acute Care Surgery Research and Chief of Emergency General Surgery for the Division of Trauma and Acute Care Surgery at Los Angeles General Medical Center. Dr. Martin has had a tremendous amount of experience with 5 combat deployments to Iraq and Afghanistan, where he has served in a variety of leadership roles, ranging from commander of a forward surgical team to the chief medical officer responsible for all surgical teams in Iraq and Syria. Dr. Martin, thanks for joining us.
Hi, guys. Thanks for having me.
Hey, Matt, again, thank you for joining us for this podcast, which is really an important podcast for those who are new to deployment or haven't deployed to a Role 2. So I thought we'd start by framing this discussion. Let me just give you a scenario. You're finishing up your deployment at a Role 2, and your replacement has reached out to you looking for some advice, trying to get a handle on what they are walking into after you're gone. This is your replacement's first deployment as they recently graduated from residency. So let's keep that as a background. Before we start with setting up some expectations, can you define for us what a Role 2 means in the military, and what is the clinical goal of a Role 2 MTF?
Yeah, so that's a great point, is understanding the role and echelon system. And probably the most important part of getting ready or succeeding in any deployment isn't necessarily knowing how to do surgery, right? We all know how to do that. It's understanding your unit's capabilities and your place in the larger system in theater. And if you look at 90% of the problems that happen, it's people not understanding their role in that system. So a Role 2 is the second echelon of care, starting with a Role 1, which is usually a battalion aid station or other forward element that does not have surgical capabilities. And traditionally, a Role 2 is the next echelon and is the first echelon where you will have damage control surgery capabilities. And by doctrine, the mission of a Role 2 is exactly that. It's damage control surgery, life, limb, saving procedures, and then stabilizing patients to move on up the echelon to Role 3. Now, I'll just say that's traditional doctrine. How that actually plays out will vary a lot. In Iraq and Afghanistan, we saw that doctrine switch to where Role 2s were doing more definitive surgery than is typically described in their mission statement. Main mission of a Role 2 is damage control surgery and then moving the patients along the evacuation chain.
Yeah, that's a great point, talking about how the mission or the goal at the Role 2 can change over time based on your theater and the current operational environment. What about your own experience at different Role 2s that you've been in during your deployments? Have they all, it's not one size fits all, I'm assuming. How have the elements changed or what you saw change during your experience?
Yeah, well, obviously, anything will change when you're at war for 20 years, which I hope we never do again. At the end of the OIF experience, we had these heavily supplied and fortified Role 2 facilities that really were almost Role 3 capabilities that we certainly won't see, especially in the early phases of any future conflicts. And it's not only your place in the theater and changes, it's even between patients, right? Because how you handle a local national civilian who you're taking care of will be different than a local national military, will be different than a U.S. military. And you need to know all those different pathways. And I'd say that's probably the most disorienting thing when you first arrive at your unit or in theater is figuring out all those different pathways and processes and where you fit into the system. But I'd say we saw the Role 2s really expand their mission from just forward damage control surgery to offering more definitive and more hold capacity because we just didn't have the Role 3 facilities to put them everywhere we were trying to cover. So they were used as almost Role 3 lights, and they were also started to do things like split them. So for forward surgical teams, which are about 20 people designed to do damage control surgery for about 48 hours continuously, those were in most instances being split into smaller 8 to 10 person elements to cover 2 locations. So very different than what is traditionally described in the doctrine for a Role 2.
So briefly, I guess kind of clinically speaking, just on a kind of high level, where we're very used to our civilian trauma centers, where we're working day in and day out. What would you say are the major differences between what we experience here stateside versus in that Role 2 environment?
So I'll say what are they lacking and what are the things that I actually think might be better. So, the first thing obviously is what are you lacking? You're a small group, typically 10 to 20 people. You have basic OR capability. You will have basic supplies. It'll include all your usual stuff, usually bovie, suction, drain, suture, etc. But you will not have any subspecialty support. You won't have, interventional radiology an option. You will not have a CAT scan unless it's some very rare circumstance. You will have an ultrasound. You may or may not have a portable x-ray. You will have some basic labs. So you won't have advanced imaging. You won't have any IR capabilities. You won't have any subspecialists backing you up other than yourself as a general/trauma surgeon, orthopedic surgeon, who you may or may not have, and then depending on the configuration now, potentially an emergency medicine physician along with your anesthesia provider. Usually it'd be a CRNA. So those are kind of the things you're lacking that you have at your typical level 1 center. Now, what's better? You are a small team and your mission is trauma. Different than your hospital where the ER has multiple missions, part of which is trauma. Most of the hospital actually doesn't participate, front facing in trauma care. So you've got a team that's small, that's fully focused on trauma care. You can train that team, as you see fit. There are no barriers. So your ER tent people are the same people as your OR tent people, are the same people as your recovery room ward tent people. So you can do things and do things much faster. I'll just say if I'm shot in the abdomen, I would rather get care at my split FST and FOB Ghazni, Afghanistan than at any of the level 1 trauma centers I work at in the States. Because I know I will get there, I'll probably get an IV or 2, and I will be on the OR table within 5 minutes, getting hemorrhage control and then surgical management of those injuries. So you actually see a lot of things where you are better, I think, at the core mission of trauma surgery. You also realize very quickly, you know what? I don't miss not having a CAT scan a whole lot. Every once in a while, for a patient with a suspected TBI, okay, yeah, it might have been nice to have a CAT scan, but otherwise, it did not bother me at all in most situations for combat trauma to not have a CAT scan. In fact, again, I think in many ways it helped care.
Matt, thank you for putting that positive spin in an austere environment. I'm particularly interested in your comments about the CAT scan because I think that will be a departure for most young surgeons and will really mandate that they rely on their clinical skills of physical examination, critical thinking skills to get that patient through the process. So I appreciate that. When I deployed as part of a role two, a very small expeditionary role two, as part of the Navy, one of our sort of Achilles heels was blood or access to blood. I wonder if you can make some comments about what the role two looks like and access to blood and how to resupply and what's the role of the walking blood bank.
Yeah. So, and again, that's something that I'd say drastically changed over time. For example, when we first deployed, we'd be carrying 10 units of pack cells, and that's it. That gradually expanded to carrying pack cells and plasma, but you will almost never have platelets in a typical roll two setting. And now you'll be carrying, hopefully, cold stored whole blood, and you have to have a walking blood bank process where you can get warm, fresh blood because you will very quickly exhaust your blood supply. And then your resupply system, again, that'll just vary by the theater and the conflict and the resupply capabilities you have. Again, I'd say we got spoiled in OIF, OEF, where we own the air. Resupply was generally very easy. In future denied care environments, you probably will not be able to count on that. So you might have a prolonged period where you don't get any resupply. And if you don't have a walking blood bank program, you're going to be out of business with one or two patients who are bleeding significantly.
That's a great point. I want to circle back to something that you said earlier about the team members at the Roll 2. We're all used to having interventional radiology, neurosurgery, orthopedic surgery kind of at our fingertips to help us out managing these complex trauma patients here stateside. But as a junior trauma surgeon about to be deployed, how do I prepare myself to manage some of these complex injuries that I'm going to be the only surgeon there for? Is there pre-deployment training that you would recommend, or is there something that I can be doing now to help operationalize myself in the deployed setting? Specifically, kind of talking about orthopedic injuries and some of the more nuanced things that we don't necessarily take care of stateside.
So I'd say a couple things there. One, that's an important concern, and I think if a surgeon's deploying and they don't have that concern, they don't understand what they're about to get into. A couple things. One is learn from people who have done this before. So pick up one of the books that's out there, Emergency War Surgery Manual, our book, Frontline Surgery. I would read, and Top Knife. I would read those cover to cover before you deploy. I would reach out to whoever is at the unit you're going to and find out exactly what they're doing, what they have, and also what they're missing. Like every deployment, I carried a rucksack of supplies in with me from, the surgeons told me, oh yeah, we have this, but we don't have this, and bring in supplies that they're missing. But, and I'll just say, we'll stick with role two, traditional role two, because we won't talk about austere surgical teams, where it's a 5-person team with one surgeon. Role two, you're very rarely going to be alone. You'll always be paired with one other general surgeon or an orthopedic surgeon. It'd be very rare you would be completely on your own. So that's huge right there, is you have another surgeon to help out and to bounce things off of and figure out the best plan of care. And then the other thing is remembering the nice thing about your mission is it's damage control and move the meat, as we would say. So you're not going to be doing, complex pelvic reconstructions. You're not going to be doing intramedullary nails. Most of the stuff in a war is going to be blast, trauma, mangled extremities or amputations. And your surgery is just washout, debridement, splint, maybe at the most apply an X-fix. And I think the Asset Plus course that USHS is running at multiple locations is great because it has a module on placing external fixator. I'd say that's, in general, is probably the most advanced orthopedic intervention you'll need to know. And a good chance you'll have an orthopedic surgeon with you who will be able to do that. But even if they don't, placing on an X-Fix isn't too hard to figure out. But even if you can't, washing out, breeding, splinting, and then moving them on to the next location that has those capabilities. And I'd say everything else then you are trained to do as a general surgeon. You know how to do a thoracotomy, you know how to do a sternotomy. You might not be super comfortable, but you know how to do that. You know how to do a laparotomy. So it's just really sticking to those basic principles and not going out on a limb and doing anything crazy, and understanding your place in the system and not spending 8 hours, trying to do some kind of complex reconstruction when you're just going to ship them off to a roll 3. And they would have been better off if you just temporary close their abdomen and ship them on.
Yeah, that's great. So that's our role as in the clinical side of things as the trauma surgeon, damage control surgery, damage control resuscitation. How does our role in terms of the leadership at a role 2, what does that look like?
Well, and this is the question I've asked. I've asked at a couple talks I've given. How many people have deployed, and a bunch of surgeons hands go up? And then how many of you were in a leadership position? And then very few of those hands go back up. And I say you're all wrong. If you were deployed as a surgeon, you are a leader. And you'll see that even if you're not in a leadership position. You'll have an FST commander and an admin, deputy commander. But when a patient comes in, nobody's looking at that MSC officer. They're looking at you and the other physicians of, Jesus, what do we need to do with this patient? In fact, that MSC officer is looking at you too of, okay, what do we need to do with this patient? So if you're deploying as a surgeon, you are a leader, whether you have a leadership role or not. I think it's great professional development to have a formal leadership role, and to lead an FST as a commander is a great experience, but you don't need to be a leader. So you just need to realize that all eyes are going to be on you. When a patient comes in, you are a leader. You need to act like it. You need to direct the team. You need to minimize any disruptive or negative behaviors. Going in there and being a prima donna and yelling at everyone and then throwing instruments in the OR, that is not going to get you very far. And that's bad in a level 1 trauma center, with 400 beds. That's poison in a roll 2 with a 10-person team. Your team will be mission incapable and dysfunctional, and it'll be a miserable deployment for you and everyone else.
It's great points, man. I think this concept of de facto leader is really important. And for the new surgeon that's deploying downrange, they have to embrace that, and they have to prepare for that and change their mindset. And we've all, in our training, in our practice, we've all seen good leaders who don't have the title, and we have to adopt those behaviors.
And actually, one point I'll add on to that too is, don't forget about your admin side and your career side. And we don't think about that or talk about that enough, because you're going to have OERs or OPRs or fit rep, which depending on your service, and you're going to be up for promotion, and they're going to be saying, well, what have you done in leadership? And if it just says, did a deployment as a gen surgeon NOS, okay, great. So, give your people some kind of title. They can go on their OER, like you're the chief of surgery for this unit. That bullet on your OER will generate you a lot of points, on the promotion board versus I was just a general surgeon. So don't forget about the career side of things.
Yeah, great tip. So just getting back to the construct of the team, although in many roll 2s, there'll be another surgeon, be it an orthopedic surgeon or another general surgeon. What if you need help beyond that? Who can you call when you need a little bit more than just your buddy who's deployed with you?
And that's why you know your place in the system, right? You are going to have a roll 3 somewhere that is your next facility you send patients to, at least US and NATO. Sometimes you can't send local nationals there, and they will have usually a lot more surgeons, and usually some more gray-haired surgeons. So you can reach out to them, email or phone, or any of the internet, WhatsApp, Signal, whatever works in your theater. And then the other thing I has found is the civilian community or your military community back in the States, they will never deny you anything. Like I have never had anybody not like immediately take a call and give me advice or even, mail some supplies. So you'll reach out and, you'll have a network. You'll reach out to the people who trained you. I had a pediatric patient I wanted to do with. I'm reaching out to Ken Azaro, who was my program director. I had a bad ENT injury, and I'm reaching out to, my roommate from Baghdad, who's an OMFS surgeon. Utilize your network, both in theater and back home. You know, once they kind of tell you how to approach it and think about it, you're able to handle most of these problems, even if it's something you've never done before. It's still surgery, right? It's still cutting and dissecting and sewing, and you'll be able to handle it, and you'll know what to do with it. And then again, having the person with you, whether they're general surgeon or ortho surgeon, just takes a huge load off your mind of just being able to bounce things back and forth. And a lot of times you're muddling through something together. And that's a lot better than trying to do that alone, especially as a recent grad deploying.
That's great, great points. I think the idea that you can always call somebody that's gives young junior surgeons, I think it empowers them a little bit to say, hey, you may be alone right now, in person, but there's always somebody that you can call. So I wanted to just kind of hit on some of the operational considerations when working at a role 2. Are there any security differences, or how does the security setup different than a role 2 or a role 3? Or does it just kind of depend on what the operational environment is?
Yeah, it's highly variable. Obviously, it'll depend on where you're located, what type of conflict you're in. Like again, a future war with a peer, near peer, is going to have a lot more security concerns than we had in GWAT, where in general you're on a base. I'd say a couple things. So again, we'll steer clear of the austere surgical team, where you might be far, far, far forward, and you're part of the security. In general, you're on a base. You're a role 2. Security is not going to be your mission. You're going to have somebody there who's dedicated to the security of that base. So I would just say, don't worry too much about it. Your security is going to be provided for. But as the leader, if you're the leader of that unit, you need to know what's the security system, who's providing it, what's the backup. What happens if there's an indirect fire attack? What happens if there's a direct attack on your base? And I've been on a couple bases where there were direct attacks and, we were sheltering in place. But if you're relying on your surgical team to actually be your security element, you are in big trouble. It's like, again, if I'm having to fire my pistol at an enemy, if it's reached that point, I'm probably better off just throwing it at them.
Yeah, along those lines, first of all, those are sage.
Sorry, but let me add one other thing. What you really need to understand and be aware of and make sure it's happening is, what's the process for especially local national patients that are being brought to your unit? What's the process for searching and securing them? Because I've been on some bases where there was nothing being done. And, we had some of them brought into the unit and they would have a grenade on them, firearm, and nobody knew it. And that's where you need to take action and say, this absolutely cannot happen again. Here's where they get screened. Here's where they get searched, and they don't come anywhere near your medical facility until that's been secured. So that aspect of it, you really need to make sure is in place.
Good point. Really, really smart. Let's talk a little bit about the resources available to you at the role 2. And you commented a little bit about resupply during OEF and OIF. And it's probably going to look differently in the next conflict. But are there any tricks or common sense moves that you should undertake for sort of preserving resources and balancing DCS and DCR in that resource constrained environment?
Yeah. So a couple things. One is you have to communicate with whoever's there ahead of you, like I mentioned before, and find out, what are you doing? what's your supply situation? What are the things you're missing that you really need? And see if you can fill that need. When you get to the unit, one of the first things you want to do is you want to walk through, starting from patient arrival, ER tent or whatever you're calling it. Just look on the shelves, look through all the supplies, and then most importantly, go to your OR tent. And I would do this in every deployment. I would just walk through and look at all the supplies I had. And then you get a very quick understanding of, okay, here's what I have. Here are the things I don't have. And here are the things I can substitute for things, I wish I had. Or if I don't have a certain type of drain, I usually use, okay, but I can use this other thing as that type of drain. Or what kind of suture do I have? Okay, I don't have my usual, but we have this suture. What kind of staplers do I have? And then if there are things that are deficient that you've noticed, reach out to your role 3 and ask if they can send you some, or reach out back home. And I had many packages shipped in with supplies. You also get a good sense of what you're short of, what you need to preserve. You might be short of staplers and reloads, and, doing all those bowel transections, just, do them without using a stapler. Do them like we used to do them, or dividing the mesentery, so things to preserve the supplies. But in most of these scenarios, you'll see you have the basic core set of supplies that you need, but it's understanding too where I can substitute things. A couple specific things though you really want to look for is make sure you have some amount of pediatric critical supplies, because generally you won't be given those through the formal system, and in many scenarios you'll be taking care of kids. A couple pediatric ET tubes of different sizes, a couple pediatric Foleys, NG tubes, and then central line kits. Have a couple pediatric size central line kits, and central line kits are like one of your most versatile pieces of equipment, because you can use those as drains. You can use those to do thoracentesis. I put in, a cordis as a pericardial drain. So have a lot of central line kits, and just realize where you can improvise the stuff you have and use it in different applications.
Great tips. So, Matt, what are some of the things you wish you had known prior to your first or even subsequent deployments to a Role 2 environment?
So one, I wish I knew how important the interpersonal stuff and teamwork component was, and how quickly dysfunctional that can make your unit. One thing I advise anyone who's doing this is have a team meeting every day, or, at least 5 days of the week, even if it's just 15 minutes every morning where you get your team together. Just say, hey, here's what's going on. Here's the plan for the day. I went to one FST where they weren't doing any meetings. I was there for 2 weeks and I still hadn't even met the whole team. And, this is 20 people. And that unit was the most dysfunctional, low morale unit I've ever been with. And units where they get together, they talk about things, set up some kind of educational program. Like, okay, we're going to do a grand rounds talk every 2 weeks. That also helps reduce issues where there's a lot of unstandardized care, and you get everyone on the same page of, okay, here's how we're going to resuscitate. If they have a mangled extremity, they're going to get 4 of packed and 4 of plasma, or 4 of whole blood immediately. Stuff like that. You have a talk on it. Everybody gets on the same sheet of music pretty quickly. And then understanding your place in the system. I wish somebody had talked to me more about that for my first deployment. Because again, I remember that was the most disorienting thing of, well, hold on. Oh, I can't send a local national civilian to the Role 3, but I have to figure out some local hospital. But if they're military, they might go here. Or if they're border patrol, they might go here. And understanding how that works and what all those different pathways are. And I think one of the best things you can do for the person who's coming in to follow you is put together some kind of written document that goes through all that. When I got to Baghdad, they handed us a thing called the Volume of Experience. And it was like this 20-page document that just had, here's all our lessons learned. Here's how you dispo all these different kinds of patients. And that was fantastic. And we put together one at one of the Role 2s I was at and passed that on to the next group. And I think that really will help the next group. And if they hand that to you, take that, read it immediately, and then reread it. And that will help us overcome these drops in care. Because you'll see you have a team that's in for 6 months and they get really good. And then a new team comes in, drop in care. Then you get better. 6 months later, new team comes in, drop in care. 6 months or a year, depending on your length. And in fact, one NCO said, we're not 10 years into our experience in Iraq. We're on our 10th 1-year experience in Iraq. So just remembering you have a lot of frequent turnover, and it's like mini Walker dips. Mini Walker dips every time you have a unit turnover or the providers turnover.
I think that was great. I don't have a whole lot to add there. I mean, this has been extremely insightful. And I know that I've got a deployment coming up the next year. I'll take a lot of this stuff with me. So do you have anything else to add there, Dr. Yelon?
No, I think those are great lessons learned, points for the deploying surgeon to embrace and take them to heart. Preparation is key, understanding your role is key, and dealing with the entire team is vital for success.
And then I'd say the final thing, or kind of the end of deployment issues, and especially if you're in a leadership role, and common heartaches at the end of deployments are around OERs or OPRs or fit reps and awards. So if you're a leader, start thinking about what awards you're going to submit your people for and how to do that objectively, and then doing their OERs, OPRs, fit reps, and doing them correctly and giving them something that's going to help their career. And I've seen a lot of units just at each other's throats at the end over those two issues. So don't forget about those issues of taking care of your people administratively.
And like you said earlier, we as the trauma surgeons, we are all leaders in that role. So I just want to thank everyone for joining us on Frontline Surgery, Mastering Military Trauma Care. And again, thank you, Dr. Martin, for joining us today. It gave us some really insightful information, some lessons learned about life at the Role 2 environment. This has hopefully provided everyone with extremely helpful discussion and on what you can expect in your next deployment.
We hope today's discussion gave you practical tools and perspective as you prepare for your role on the front lines. Until next time, stay sharp, stay ready.
And if anyone is interested in seeing an example of one of these handoff documents, in the show notes there's a link to a file called Forward Surgical Team, Combat Trauma Volume of Experience, Protocols, Practices, and Lessons Learned. That's an example of a document we put together at one of our forward surgical teams to turn over to the incoming unit.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.